Let's jump right into these Step 2 CK clinical pathways for rheumatology, immunology, and systemic diseases. We'll be hitting crystalline arthritis like CPDD, sarcoidosis, erythema nodosum, and wrapping up with crucial immune deficiency patterns and strict vaccine rules. But first, let's tackle a classic mechanism trap involving hypercalcemia. With hypercalcemia, these patients are almost always hypovolemic because of polyuria. The high calcium actually induces nephrogenic diabetes insipidus, causing them to dump massive amounts of fluid. So if you reach for a loop diuretic right away, you're just going to worsen that volume depletion. You absolutely have to avoid loop diuretics here unless they specifically have concurrent heart failure or obvious volume overload. Your management branches are directly tied to severity. For severe cases, meaning calcium is over 14 milligrams per deciliter or the patient is symptomatic, your immediate next best step is aggressive normal saline hydration and calcitonin. Once they're stabilized, long-term management shifts to bisphosphonates, like zoledronic acid. Now, for mild, asymptomatic cases where calcium is under 12, they don't need immediate treatment, but you definitely want to avoid triggers like thiazide diuretics, lithium, and further volume depletion. Diagnostically, the absolute first thing you check is the parathyroid hormone level. If the PTH is suppressed, that points you away from the parathyroid entirely. From there, an elevated PTHrP screams malignancy. Think squamous cell, renal, breast, or ovarian cancers. But an elevated 1,25-dihydroxyvitamin D, that heavily suggests a granulomatous disease like sarcoidosis. What's happening is the activated macrophages inside those granulomas actually increase the conversion of vitamin D into its active form, which drives up calcium absorption. Speaking of sarcoidosis, let's trace that pathway. It's a multisystem granulomatous disease. Your classic clinical clues on the exam are a young black woman presenting with dyspnea on exertion, a nagging cough, and bilateral hilar lymphadenopathy. You might also see anterior or posterior uveitis, facial nerve palsy, central diabetes insipidus, or even an AV block. If you suspect it, your best initial test is always a chest x-ray. The most accurate test, though, is a biopsy of an accessible lymph node or organ showing non-caseating granulomas. This helps rule out TB, fungal infections, or lymphoma. If they're asymptomatic, you just observe. But if they have symptomatic pulmonary, ocular, neurologic, or cardiac involvement, or severe hypercalcemia, you need to initiate systemic glucocorticoids. Now, a very common exam finding in sarcoidosis is erythema nodosum. Pathologically, you need to remember this is strictly defined as a septal panniculitis without vasculitis. It's essentially a delayed type hypersensitivity reaction to some kind of antigen exposure. When you examine the patient, you'll see these incredibly tender, indurated erythematous nodules right on the anterior shins. They typically resolve on their own over a few weeks and just leave behind some residual hyperpigmentation. But you can't just stop there. Identifying the underlying trigger is absolutely crucial. You cannot treat erythema nodosum just as a skin issue. It's a massive red flag for systemic conditions. It's heavily linked to streptococcal infections, inflammatory bowel disease, sarcoidosis, pregnancy, antibiotics, and oral contraceptives. Endemic fungi like coccidioids and histoplasma, plus Behçet disease, are also classic triggers to watch for. Because of the strong link to sarcoidosis and TB, the next best step when a patient presents with these nodules is a routine chest x-ray. Treat the underlying trigger and offer supportive care. Let's pivot to acute monoarthritis, where you have to differentiate disseminated gonococcal infection from crystalline arthritis like gout and CPPD, also known as pseudogout. CPPD typically presents as an acute inflammatory monoarthritis, often in an older adult, and it loves to target the knee or the wrist. The presentation really dictates your diagnostic branch here because both DGI and crystalline arthritis can show up as a hot, severely painful, swollen joint. If the patient has a tender necrotic acral pustule alongside a purulent monoarthritis or maybe an asymmetric migratory polyarthralgia with tenosynovitis, you are definitely looking at disseminated gonococcal infection. That specific dermatosis is a massive clinical clue. To nail the diagnosis, you have to draw synovial fluid, which will show an inflammatory effusion with neutrophil predominance. For treatment, you start them right away on intravenous ceftriaxone. You only switch them to oral cefixime once you clearly document clinical improvement. And don't forget to empirically treat for a common comitant chlamydial infection using azithromycin or doxycycline. On the flip side, acute crystalline arthritis can present with severe erythema and swelling in a single joint, or even as a large, fluctuant chronic effusion over a superficial bursa, like olecranon bursitis. If you run a synovial fluid analysis, you're looking for negatively birefringent crystals for gout or rhomboid-shaped weakly positively birefringent calcium pyrophosphate crystals for CPPD. You might also spot chondrocalcinosis on an X-ray. But here's a major exam trap. Do not let the presence of crystals stop your septic arthritis workup. If the joint is hot, severely painful, febrile, or the patient is high risk, you must send a gram scan and culture, because an infection can absolutely coexist with crystals. Also, remember, CPPD has strong risk associations with hyperparathyroidism, hemochromatosis, hypomagnesemia, hypothyroidism, and recent joint trauma or surgery. When it comes to treating acute crystalline attacks, NSAIDs, colchicines, or intra-articular glucocorticoids are your go-to options, but you have to check their renal function, GI risk, and anticoagulation status. While NSAIDs and colchicine are great first-line choices, they are absolutely contraindicated in patients with renal failure. If their kidneys are failing, skip those entirely and go straight for intra-articular or oral glucocorticoids to suppress that inflammation safely. There's another classic NSAID trap with seronegative spondyloarthritis. Imagine a young male with inflammatory back pain that actually gets better with exercise, but he also has a history of diarrhea. If you give him NSAIDs for the back pain, it will help his back, but it will trigger a dangerous exacerbation of his underlying inflammatory bowel disease. If you suspect ankylosing spondylitis, getting diagnostic imaging is key. You're specifically looking for this pathognomonic widening of the sacroiliac joint space, along with subchondral sclerosis. And while most folks with ankylosing spondylitis don't actually have a reduced life expectancy, you still have to monitor them closely for some very specific, severe complications. We're talking osteoporosis that can lead to vertebral fractures, aortic regurgitation, and cauda equina syndrome. Let's shift gears to distinguishing different myopathies based on how they present and their lab findings. Fibromyalgia presents with widespread trigger point tenderness, but totally normal labs. Polymyositis gives you proximal muscle weakness with significantly elevated muscle enzymes like creatine kinase. Then you have polymyalgia rheumatica, which typically presents in patients over 50. They'll have severe stiffness in the shoulders and hip girdle that feels way out of proportion to their actual pain, plus an elevated ESR. Polymyalgia rheumatica on its own responds incredibly fast to low-dose glucocorticoids, but it is strongly associated with giant cell arteritis. And if they have that, they absolutely need high-dose steroids to prevent irreversible blindness. For polymyositis or dermatomyositis, there's a strict rule. All diagnosed patients have to be aggressively screened for occult malignancies. Think ovarian, lung, pancreatic, and colorectal cancers, as well as lymphoma. Moving over to myasthenia gravis. The clinical presentation really hinges on fluctuating, fatigable proximal muscle weakness. Ocular symptoms are huge here, diplopia and ptosis, along with bulbar symptoms like dysphagia or dysarthria. You can support the diagnosis right at the bedside with the ICE-PAC test and then confirm it with highly specific acetylcholine receptor antibodies. Now, certain medications are strictly contraindicated in myasthenia gravis. Fluoroquinolones, magnesium sulfate, and beta blockers will directly block neuromuscular transmission. If you administer any of these, you can easily trigger a life-threatening exacerbation. If a myasthenic crisis does occur, often triggered by infection, surgery, pregnancy, or one of those contraindicated meds, the patient will show up with severe oropharyngeal weakness and respiratory insufficiency. Your absolute first priority is securing the airway with intubation for that deteriorating respiratory status. Do not jump to medications first. Only after the airway is totally secure do you move to rescue therapies like plasmapheresis or IVIG plus corticosteroids. Let's talk about Sjogren's syndrome. For a patient complaining of keratoconjunctivitis sicca, or severely dry eyes and dry mouth with an autoimmune background, the best initial blood tests are the anti-Ro and anti-La antibodies. But the best overall diagnostic tool is the Schirmer tear production test, which uses a little strip of filter paper on the eye to give you an objective measurement of decreased lacrimation. We're wrapping up with immune deficiency patterns and vaccine roles because, just like rheumatology, your patient's underlying comorbidities dictate all your treatment traps. Let's break down the patterning. B-cell defects cause recurrent cynopulmonary infections with encapsulated bacteria. T-cell defects lead to severe viral, fungal, mycobacterial, and opportunistic infections. And remember, you must absolutely avoid live vaccines in severe T-cell immunodeficiency. Phagocyte defects lead to deep bacterial and fungal abscesses, while complement terminal pathway defects cause recurrent Neisseria infections. Now let's look at a few specific defects. Chronic granuloma disease, or CGD, is an NAPDH oxidase failure. These patients get catalase-positive infections and granulomas, and you diagnose it with an abnormal DHR test. For management, you use TMT-SMX, itraconazole, interferon gamma, and culture-based treatments, and definitely avoid live bacterial vaccines like BCG. Then you have leukocyte adhesion deficiency, or LAD. The classic exam presentation is delayed umbilical cord separation, poor wound healing with absolutely no pus, and striking leukocytosis with neutrophilia. And don't forget hyper IgE syndrome. Look for eczema, cold staph abscesses, recurrent sinopulmonary infections, retained primary teeth, and of course, high IgE with eosinophilia. Finally, let's lock down these vaccine rules. Asplania causes a severe infection risk from encapsulated organisms, so these patients absolutely need pneumococcal, Hib, and meningococcal vaccinations. For HIV patients, they should receive all their indicated inactivated vaccines, but live vaccines, specifically MMR and varicella, are strictly contraindicated the second their CD4 count drops below 200. Pregnancy also strictly avoids live vaccines. Oh, and if you see an egg allergy on the exam, in this specific context, that mainly matters for the yellow fever vaccine. Keep these organism patterns and contraindications straight, and you'll easily navigate these high-yield scenarios.